Welcome to the Clinical Podcast series brought to you by the American Academy of Optometry Foundation. The topic for this episode is factors associated with faster axial elongation after orthokeratology treatment. I'd like to thank our host, Dr. Dave Kading, our topical expert, Dr. Safal Khanal, and our topical lead editor, Dr. Andrew Pucker. And now it's my pleasure to begin today's broadcast.
Well, thank you for joining us today for the clinical podcast series. We're excited to be sharing with you some interesting research on myopia management and in orthokeratology, axial length, soft lenses, soft multifocals, atropine, and all the other great stuff that's happening in myopia management. I am very honored to be joined by Dr. Safal Khanal. And he is really leading the world in some of the knowledge that we have here. And I'm excited to get to have him as a guest to talk with us a little bit. Thank you, Dr. Khanal, for joining us for this episode.
Thank you for having me.
Yeah, absolutely. So you are at the University of Alabama. Is that correct? Give us a little brief overview of what you're doing.
So I'm a faculty in the School of Optometry at the University of Alabama at Birmingham. Here at UAB, I run a myopia research program focused on basic and clinical myopia research. My lab works with both animal models and humans, and really the focus is to understand mechanisms of myopia development and progression, and also to investigate interventions to prevent the onset and slow the progression of myopia in children.
That's awesome. That's awesome. And I know you've had your fellowship in the academy, so we appreciate your contributions. But today we're focusing on a publication that's called Factors Associated with Faster Axial Elongation After Orthokeratology Treatment. And such an important topic here is because I do ortho-K in my clinic, and I'm always kind of curious, are there things that would, push people to go faster or slower? Can you give us a 30-second overview of the background of this paper that you're reviewing?
Well, I found this paper directly relevant to ODs practicing myopia management because it addresses various factors that may be associated, as you said, with the rate of axial elongation in children undergoing orthokeratology treatment for myopia control. Orthokeratology, as we know, is one of the most effective interventions out there to slow myopia progression in children. But and we also know that the average efficacy is around 50%. But this average efficacy does not necessarily always translate to clinical practice. Oftentimes, children treated with ortho-K lenses can show less than the desired efficacy, and still can show a faster rate of axial elongation. So this presents a dilemma as to how to predict which child in the treatment chair is going to respond well and which child won't respond well. That's where this paper provides useful information about some of the factors that could be important in considering which kids are going to respond less optimally and which kids are going to progress faster, even when they are being treated with orthokeratology.
Yeah. What did you find were some of the key findings of the article that really kind of struck you as being important?
Well, this was a retrospective study in which the authors reviewed records from about 73 children undergoing orthokeratology treatment for 1 year. They collected baseline data on several demographic and ocular factors such as age, gender, parental myopia, refractive error, and so on. And they looked at the association of these baseline factors with the axial length change after 1 year of treatment. They found that factors associated with faster axial elongation were low baseline myopia, a high degree of parental myopia, and also younger age at onset of treatments. These factors, to a large extent, are also consistent with the natural progression of myopia in
Right.
children. And so this paper has shown that these determinants are also true for children being treated with orthoke lenses. And younger children, those with low myopia and both parents myopic, appear to show a faster rate of axial elongation. And older children with moderate myopia and one or no myopic parents appear to show a slow rate of axial elongation when
Yeah.
they are treated with orthoke lenses.
Yeah, I think the key takeaway from that's a fantastic overview, is that in clinical practice, if I was to start a 15-year-old and to start a 7-year-old on treatment, I would expect the younger child to progress faster. And that's kind of what the studies showed, is that, as kids would progress faster at a younger age, or both parents having myopia, we would just expect that. And that doesn't necessarily mean that the treatment isn't working. It's just we would anticipate that axial elongation would progress with or without orthokeratology at the same rate. Is that kind of your takeaway from that?
Absolutely, because these factors seem to be so consistent with the natural progression of myopia, whether the child is being treated or not, it seems that these factors are equally important. Younger child will progress faster, regardless of being treated with orthoke lenses or not.
Yeah.
But obviously, that rate of elongation with the treatment is going to be less than without treatment.
Yeah, I don't know that it does, but I'm curious from your perspective, do you think that this paper guides us any way to select patients for different treatments? Does this mean that we shouldn't do or should do, or does it not really affect the decision of fitting kids in ortho K based on their age?
Well, as we discussed, this paper has basically identified certain factors that could be related to excellent change after orthokeratology treatment. And these factors are younger age at onset, low magnitude of myopia, and strong parental history of myopia. So essentially a subset of children which we normally classify as high-risk children anyway. These high-risk children may show a faster rate of axial elongation even with orthoke treatment. So these children may actually benefit from a more aggressive form of myopia management. For
Yeah.
example, combining ortho-K with myopia control spectacles or even low-dose atropine eye drops.
Right. Yeah. Now, something that was a little bit, peculiar in this study was that there were nine, I believe is nine eyeballs or nine patients where their axial length actually got shorter. How can an eye get shorter? And is this related to the eye shape, or what are your thoughts?
Well, the question of whether eyes can actually get shorter is an interesting one. The commonly held belief is that once an eye elongates, it is very difficult to then get the eye to shorten. But from time to time, we see reports, including this one, that show regression of axial length in some children undergoing myopia control treatments. We usually see this in a small proportion of children, and it
Mhm.
is easy to overlook this when looking at the average efficacy. But even in clinical trials, there are always a handful of children that show negative axial length change, suggesting shortening of eyes. The question is, how could the eye shorten? And of course, changes in ocular components such as corneal thickness or central corneal thickness could lead to axial length shortening. But the amount of changes in corneal thickness and central corneal thickness are usually small, and as reported in this paper, the magnitude of axial length shortening cannot be explained by these factors alone. So whether these are real changes or not remains to be seen. But at least in animal models, we see that eyes can actually shorten in response to myopic defocus conditions. So one hypothesis of these authors is that perhaps the orthoke lenses changed the shape from a prolate to a more oblate shape. So that's how maybe the central axis got shorter. But really, this speculation really needs further investigation.
Yeah. Yeah, and this is probably in a subgroup who didn't, didn't progress much in their axial length from an elongation standpoint anyway, and so maybe that corneal flattening possibly could have had some part of this. Well, it's certainly a very interesting paper. I appreciate you giving us an overview of it. Any last closing thoughts? Anything to add?
Well, I just want to add that with any treatment, there are always going to be children who respond well to the treatment, and there are going
Yeah.
to be non-responders. So, looking at the baseline factors and trying to gauge the risk profile of each and every children is going to be important in making sure that the treatment we administer is making a difference to their myopia profile.
Absolutely, absolutely. Well, we sure appreciate you being on the clinical podcast series. Thank you for your contribution to the Academy, and we're really looking forward to some of your research and your work coming out as well. And thank you, the listener, for joining us for this clinical podcast series. Make sure to stay tuned for future episodes.
And a special thanks to Cooper Vision for their educational grant to make it all happen.